published that in this paper, showing that second hit DEPDC5 mutations were limited to the dysmorphic neurons. Now, we just switch now to something I mentioned earlier, the new kid on the block for FCD, this entity called MOGI, where you have heterotopic neurons, they're normal neurons, associated with oligodendroglial hyperplasia. And this tends to cause a very severe early onset epilepsy, particularly infantile spasms. And to treat these patients, you often need to do very large resections. The lesions are often quite large. There's two imaging patterns. In the younger child, you might see this subcortical high signal in a linear subcortical pattern. As these patients get older and myelinate, you sort of lose that and get this very broad area of small grey-white differentiation. Now, the two groups did very large studies with a large number of patients that had had epilepsy surgery. The group from Korea, using tissue and blood, were able to identify the cause in about a third, and the group from France in about 55%. So overall, the diagnostic rate, even if you have deep sequencing and you have brain tissue, is about 50% in patients with FCD. Now, just to summarise in the last few slides, there's a large imaging spectrum from FCD, going from either normal imaging to very small lesions, all the way out to hemispheric lesions. There are different genetic mechanisms of germline mutations, particularly in the TSC genes or the members of the GATA1 complex. More commonly, FCD is caused by somatic mutations, particularly in the mTOR gene, but also a number of others. And rarely, people have looked, not everyone's been able to do this work, and two hits have been found, one germline and a different one in the brain tissue. This has been shown occasionally for TSC, but also for DEPDC5. The majority of mutations, however, for FCD will be in mTOR pathway genes or in the gene causing MOGI, which I haven't mentioned yet. The gene that causes MOGI is SLC35A2. It occurs, it's been found only as a somatic mutation, therefore in brain tissue to find it. This is a gene causing glycosylation. We don't yet know why it causes a malformation in epilepsy. So, last couple of slides, some take-home messages. MRI pattern recognition, genomic sequencing and brain tissue sequencing have been the three most important advances in understanding the genetics of MCD. However, we still don't know the causes for the most common FCD, don't know all the causes. PMG diagnostic rate about 30%. FCD, even if you have brain tissue, diagnostic rate still only about 50%. And for periventricular nodular heterotopia, which I haven't talked about today, the diagnostic rate is very low unless it's a filament A pattern. mTORopathies can cause both FCD and PMG. There's different models, as I've mentioned, germline, somatic and two-hit. One gene can cause many phenotypes. One phenotype can have many genes, which as I've shown you for this differently. There can be variable expressivity and variable penetrance. It can make genetic counselling quite difficult. In addition of which carrier parents can be mosaic and unaffected occasionally. There's limits to our current sequencing technologies. Clinical testing is often low depth and low coverage and may not pick up all the mutations, particularly if they're somatic. And to diagnose somatic mutations, blood may not be the best source. And you may actually need other tissue, particularly brain tissue, or even individual neurons to find those mutations in very low mosaicism. But it's imperative on us, and I mean all of us, those working in fetal medicine, those working in neuroradiology, genetics, and in pediatric neurology, to get the phenotyping right, to do the right testing. Sometimes will require research testing, and then using all that to try and give the best possible genetic counselling. So So that's the end of my talk. I hope I'll be able to be available online to answer any questions. But if I'm not, or if you just want to contact me with any questions, that's my email address, richard.laventer@rch.org.au. Again, I'd like to thank you all for your attention and thank you to the organisers for inviting me to speak.
Thank you very much, Professor Richard Reventlow. And unfortunately, he's not here now. But if you have any questions and comments, please put them in the question box. Okay, so I would like to introduce Professor Gustav Maringel. And as for Gustavo, I don't think he needs any introduction, and he's the godfather of the fetal brain. And his main field of research are on the fetal brain and has published many articles and book chapters. And he is a senior author of the 4th edition of the ultrasonography in the prenatal brain. Please check it out. So, Gustavo, would you please give your talk?
Yes, thank you, Ritsuko, for the introduction. And following the fantastic lecture by Rick, I am going to move from the postnatal diagnosis to the prenatal diagnosis, and I will start today speaking about disorders of proliferation, and I put together microcephaly and macrocephaly because although they are in size very different, they have many things in common regarding the prenatal diagnosis. So you know that the old classification of malformation of cortical development speaks about malformation due to abnormal proliferation or apoptosis, malformation due to abnormal neuronal migration, and malformation due to abnormal cortical organization. We are going to speak about malformation due to abnormal proliferation and apoptosis. And here you have the classification. You can speak about microcephaly, megalencephaly, that is for me a synonym with macrocephaly, and abnormal proliferation, and Rick spoke a little bit about that. But today we're going to speak mainly about micro and macrocephaly. Here you have another more modern classification that was published in 2022 by the group of Professor Severino, and again, now the classification is mostly based on genetics. Now, what regarding prenatal diagnosis? Small fetal head represents, from the side of prenatal diagnosis, a big problem, but also a large fetal head represents a big problem. Why it is a problem? If you have a fetus with other malformation, or you have an abnormal microarray, or an abnormal pathological exome sequencing, there is no problem. You know that something is wrong with the fetus, and since in most of these cases it affects other parts of the brain, you know that the prognosis is not dependent of the size of the brain, but all the associated anomalies. But why is it truly a problem? It's a problem because most children macrocephaly are born with normal head circumference. Fetus with small and large head circumference are at increased risk than those with normal head circumferences. 2.3% of the normal population have a head circumference that is bigger or smaller than standard deviation. Also, there is a clear concordance between prenatal and newborn head circumference that are smaller or larger than standard deviation are rarely diagnosed by the time of the second trimester ultrasound examination. As Rick told us, one gene may have different phenotypes, and the same phenotypes can be present in two different genes. Mutations in the same gene can cause loss or gain of function, meaning that they can, a mutation in the same gene can produce also micro and also macrocephaly. somatic mutations causing macrocephaly has been described, and as Rick told us, if you have a somatic mutation, the result of the amniocentesis will be implications only. Starting with the problem how we measure, there are different tables, and it's important that you should know that if you use Hadlock, a lot of your patients will be either have big or small heads, because the standard deviation of the Hadlock curves are very thin. Today, we recommend to use the very old curves of Chervenak, because there the standard deviation is bigger, so the risk of false positives, either in the big size or the small size, become less. Now, another problem is how you measure, and this is a quite old case. The patient was referred to me at the 36 weeks of gestation. He suffered from pregnancy-induced hypertension, and the ultrasound diagnosis in an hospital were very, very different. One of the professors measured a -4 standard deviation. The second professor after that measured -3 standard deviation. The third professor measured -2 standard deviation. And I saw the patient. The head circumference was completely normal, 32 centimeters at 36 weeks. All the measurements were correct. Why they were correct? Because the shape of the head. The head has tuberculocephalic shape. So if you measure in a conus, it depends the height where you measure. So this is important to be sure that what you are measuring is the correct measurement. Now, another important thing, you see this child was born with a head circumference of 30 centimeters, and his head circumference at the age of 2 years was -4 standard deviation, but he's developing completely normal intelligence. And we know from other studies that at school age, 1.9% of the children have head circumference below -2 standard deviation, and they have normal IQ, similar to their friends in the same class. And this is because of statistics, because 2.3% are expected to have a small head and be normal. On the other side, you have here this image of a very macrocephalic child. Okay, this is pictures of myself. I was born with a head circumference of 39 centimeters that represent 3.1 standard deviation. Now I am 71 years old. My head circumference is 61 centimeters, is 4.1 standard deviation. And according to myself, not to my family, I am quite normal. Another important fact is how we define fetal microcephaly, and it's exactly the same for fetal macrocephaly. We made a study a few years ago where we found children that have a head circumference between -2 and -3 standard deviation, and all of them were developing normally when we studied them at the age of 2 to 3 years. And what is more important, 18 of 20 of these children were females. Now, following the problem, I spoke about if you perform an examination during the second trimester, the head circumference can be completely normal. As you see in this case, okay, the head circumference is growing and is normal, is not below -2 standard deviation, but as pregnancy continues, okay, there is a plateauing in the growth, and this is the head circumference after birth, okay, that is. The last examination was between standard deviation after birth is between 2 and 3 standard deviation. But what you can see is that during the last 6-7 weeks of pregnancy, the head circumference almost didn't grow. And this is the head circumference after delivery, and we found a mutation in a gene that is called a variant in a gene that is called CCNE2, and this particular mutation is known to cause loss of function. And what is very, very interesting, there was paper published with the same mutation, but what is important is that the same mutation in the same gene in another exon may cause macrocephaly, as they show in this table. You see the cause MPPH3, that is one of the known genes of macrocephaly. The protein causes it's a gain of function, okay, but the mutation is in another place, and this is a missense nonsense mutation. It causes loss of function and macrocephaly. Another problem is what you need to do when you have a fetus that is referred to you late in pregnancy because of macrosomy. They come to me after a fetal brain MRI that was considered normal. The CMA was normal, but you can see that the fetus has quite large head, and here you have the curve of how the head circumference growth. Okay, it was 1.9 at 29 weeks. It was 2.7 at 34 weeks, and 1 week later it was 3.2. It was growing very, very fast. And in this case, everything was normal. Again, you have the confidence that it was normal because of the MR. Okay, but the large head circumference, no ventriculomegaly, there was not a protrusion, there was not frontal bossing. Everything was apparently normal, and we decided that we need to recommend to go for exomics, and the exomics results in a boost variant, okay? But this boost variant, okay, was not previously described, but they wrote that these variants in the same gene, that is the CHD3, may cause a syndrome that for me was the first time I saw this name. This syndrome is called Snyder's broken paw. But since the cause of the HPO, the cause that we refer the patient for exome was the presence of macrocephaly, okay? When we look in the 35 individuals that were diagnosed with this syndrome, okay, the only thing that was present that can be diagnosed by ultrasound during fetal life is macrocephaly, that was present almost in 60% of these cases, with widening CSS spaces. So we asked a review of the MR. Okay, this is how these individuals look, and we asked a review of the MR, and you can note here that also in the MR there was an increased size of the subarachnoid spaces, and when you look at the child, the face was a little bit dysmorphic, but nothing else. We published this case in the prenatal diagnosis of this syndrome, was the second or third paper in the, but now there are more and more cases that have been described with this syndrome. Another important thing when we speak about the head circumference is the size of the head is different. The 50% is different in females and males. During the last weeks of pregnancy, the females fetuses have a head circumference that is by mean half centimeter, meaning more or less 1 week difference in size. Now, what we have regarding prenatal of macrocephaly, there are cases that have been rarely reported. I looked for macrocephaly in the title of the paper in prenatal diagnosis. They were until now there are 156 results, but until 2014 there were only 69, meaning that most of these results in this period of time, the last 10 years, have been related to Regarding macrocephaly, again I did the same work, macrocephaly and prenatal diagnosis, only 29 results. If you wrote megalencephaly in prenatal diagnosis, there are another 10 results. If you wrote hemimegalencephaly in prenatal diagnosis, only 16 results. So you see that these cases are rarely reported, and the reason that we, during the last 20 years have seen a lot of these cases is because we are a referral center. Now let's speak about microcephaly. When we speak about microcephaly, there are two different classifications, okay? But let's say that we speak of this classification, we put in one side the genetic origin, okay? And genetic may cause early onset, okay? Early onset of microcephaly is usually due to abnormal neural proliferation. About microcephaly,
Cái này nó nói là tại vì cái lúc đó là mạng rớt cái gì đó xong rồi nó bị hư hại gì không biết nữa.
I am here myself, something is wrong.
Em thử nha.
Hello? Okay, I can continue. So we have early onset. It can be a trisomies of microdeletions, also neuroconcephaly, and some very rare monogenic disorders. We can have microcephaly associated with migration disorders. This is, in our practice, more common. Microcephaly with periventricular and other heterotopia or with polymicrogyria, and in case of 17p33 deletion. Late onset post-migrational rarely will be diagnosed with pregnancy, and here you can have the pontocerebellar hypoplasias, GAS, X-linked dominance, neurodegenerative disorders, and red-like variants, and again post-migrational that extremely rare and rarely diagnosed in pregnancy are congenital. We need to remember that many cases microcephaly can be acquired. We have now the example of the Zika virus, but also we have acquired infective microcephaly due to CMV. Different types of microcephaly, we can call them primary or syndromic, postnatal, post-migrational, or acquired. This is another classification that in my impression is not very important. Now, in microcephaly, consanguinity is a very important factor. A recent paper showed that the yield of exomics when there is a consanguinity in the family is around 60 to 70%. There is no consanguinity, the chances to make a diagnosis are much lower. And this is an example. Years ago, it's a family with consanguinity. We follow the patient every 2 or 3 weeks. They were after a termination of pregnancy 36 weeks. The brain was considered normal but small. The child, they have a child with progressive microcephaly and severe mental retardation. And you see again the plateauing. The diagnosis was reached in this child years later. It turned out to have a mutation in the gene that is called ASNS. A few years later, we have this patient again with plateauing, and the mother was from the same family, the husband of same ethnic origin. He was after a termination of pregnancy because of microcephaly at 37 weeks a few years ago. The ultrasound was completely normal, the MRI was completely normal. At this time, we were not aware of the diagnosis in the other family, and the child was born with microcephaly with severe mental retardation and have eventually the same disease. These cases of extreme microcephaly with a simplified viral pattern are very easy to diagnose. They appear early in pregnancy. You see here at 28 weeks, the head circumference was -3.8 standard deviation, and they don't represent a diagnostic challenge. This is how the child looked after delivery. He passed away very fast, and something is interesting is not that he have not a big ear, but have a very small head. This another case. We saw the patient for the first time at 27 weeks, and the head circumference was -2.1 standard deviation. But from this moment, we were aware that something was very wrong. Why we know that? First of all, when you have microcephaly, in the axial planes, it's difficult to see the brain because the sutures in the fontanelles are smaller or close. But after that, even in the axial plane, you see here that the occipital horns are not well developed, and there's a lot of fluid in the midline here. And again, in the mid-sagittal plane, not mid-sagittal plane, sorry, you see again there's a lot of fluid around the brain at 27 weeks. We cannot see suffocation. Okay, the patients were not willing to go for termination, so we perform an MRI at 30 weeks that confirmed the findings, looking again the undevelopment of the occipital horns. And you see here something that is characteristic of fetuses that have eventually will have polymicrogyria, is that you see that the brain here has a round shape, and at some point it becomes like someone cut with a knife. Okay, and this is very characteristic of microcephaly with polymicrogyria. But the CMA and the exome were considered normal. Okay, this is the examination at 33 weeks. Okay, the head circumference is minus 3.5 standard deviation, and the brain is completely encephalic. So the fact that you don't find a genetic diagnosis doesn't necessarily mean that the child will be normal. And as you can see here, we prove it because the family was not willing to terminate pregnancy at 27 weeks, at 33 weeks, at 30 weeks. The findings are much more clear. Always look for associated malformations. And this is a case of very severe, perhaps the earliest case with microcephaly we diagnosed at 20 weeks, very small. It was at the time that we didn't measure the head circumference, the VPD. You see the VPD was very small, and the fetus was terminated with a diagnosis of Neulaxova syndrome with encephalocele. Remember, again, I spoke about that. Remember that we have acquired microcephalus mainly due to infections. And this is one example of a fetus that has severe CMV infection. You see that the large subarachnoid spaces, that due to the fact that the brain is small, with the presence of polymicrogyria, abnormal sulcation, okay, and a wide separation between the occipital lobes. This is another case, Smith-Leopard syndrome, and you have here callosal dysgenesis, a small cerebellum, an AV canal, and have the Opitz syndrome, Smith-Leopard syndrome, with facial edema, hypertelorism, antevertebrate nerves, short web neck, and ambiguous genital. So this is currently our protocol of a study, and again, it's very important to understand that the fact that the use of exome has become more and more common. So in conclusion, regarding microcephaly, the most common and problematic onset is when the head circumference is between -2 and -3 standard deviation. Warning signs included associated anomalies, arrest of head circumference growth restriction, IUGR, growth restriction, and consanguinity. Below -3 standard deviation, the risk of mental retardation is around 50%. In the vast majority of the cases, the diagnosis is made during the third trimester or after delivery. Now we go to large, and size again here matters, because we have this is three different conditions. You may have a large fetal head, as I told you before, and I showed you, and a completely normal person. You may have macrocephaly or brain overgrowth. Before the next generation sequencing era, okay, we published a paper on the diagnosis of syndromic macrocephaly, and we have quite a big number of patients with macrocephaly that was considered isolated, and 60 of them have associated anomalies. And when we put together our data, okay, gestational age of appearance of the macrocephaly didn't reach statistical significance, and the only calculation that made that reached statistical significance was the head circumference during the examination, Z score, that in group A, 3, and in group B was almost 3 standard deviations. Okay, or almost all the children that have isolated microcephaly were born were large for gestational age. 68 of them have a macrocephalic parent. Most of them were boys, and almost all of them have normal development, no cases of mental retardation. There was a child with autism spectrum disorder and 3 needed physical therapy. One patient decided to go for termination without explanation. In the other side, the associated anomalies included that we expected to find, that as mild ventriculomegaly, callosal anomalies and malformation of cortical development. We reached a prenatal etiologic diagnosis in only 5 cases, and in other 11 cases, the diagnosis was reached only postnatal. And this is one of the first case of macrocephaly capillary syndrome. This time we didn't have sequencing, we didn't have genetics, but you see a very big head. The child was born, and she's actually doing quite well, but she's extremely macrocephalic. This another case of macrocephaly. Again, the lateral ventricle was a mild ventriculomegaly. Okay, we didn't like the shape of the brainstem. The head circumference was large. The corpus callosum, something that's very common in these disorders, was large, and we were also able to diagnose polydactyly. The MR shows the presence of polymicrogyria, and the postnatal MRI show again the presence of polymicrogyria. We missed by also in the ultrasound, also in the MR, the presence of this hemangioma. Okay, the postaxial polydactyly was present. The conclusion of the paper was that fetal macrocephaly with head circumference between 2 and 3 standard deviation and not associated anomalies usually carries a good neurodevelopmental outcome. In particular, when there is a family history of benign macrocephaly, fetal macrocephaly associated with other CNS or non-CNS anomalies implies syndromic macrocephaly, and the prognosis depends on the specific syndrome and the association of brain malformation. And a genetic diagnosis can be suspected based on the associated findings. Syndromic macrocephaly is usually diagnosed only in the 3rd trimester. Usually there is seldom time for genetic confirmation. It has changed since then. An acceleration in head growth in the 3rd trimester usually implies syndromic macrocephaly if it reaches more than 3 standard deviations. Chromosomal anomalies may present as macrocephaly. We were speaking at this time only of CMA. Underdevelopment of the operculum is a poor prognostic sign, and the corpus callosum is frequently seen in syndromic macrocephaly and carries a poor prognosis. And this is the most severe case, and here it comes to the lecture of polymicrogyria. This is a fetus that was presented to me when I was in a congress in Singapore. The head circumference was plus 6 standard deviation, with a very thick and short corpus callosum. And you can see here that the head circumference corresponded at 22 weeks corresponded to 31. And here you can see what is polymicrogyria from the imaging point of view. Okay, you see the shape of the lateral ventricle is very abnormal, triangular, but here you see the polymicrogyria, this undulated pattern of the
Ủa giờ sửa sao? Tuổi 17 là ở đâu?
Eventually, we spoke about polymicrogyria.
Ủa nhưng mà cái phần hành chính ở phía trên là mọi người lo chứ tôi đâu có biết gì đâu, tôi chỉ lo siêu âm rồi trả xuống thôi chứ.
Now, in the next generation sequencing era, okay, we need to add to our protocol the performance of exomic sequencing. Now, when to perform exomic sequencing?
Không, em đâu có sửa gì được phần hành chính, em chỉ lít vô cái mã, em chỉ lít vô cái mã nó hiện như thế, nó lít vô cái mã xong rồi em làm siêu âm thôi chứ em đâu có đổi cái gì số tuổi của người ta bao giờ, em đâu có nhập cái gì ở trên phần hành chính đâu. Ủa thì tự liên hệ với IT đi chứ. IT, mấy người phải tự liên hệ với IT, tôi chỉ làm phần chuyên môn của tôi thôi. Hiểu không?
Neurosonography and the fetal brain MRI are normal. The exomic sequencing needs to be performed during pregnancy to reach a prenatal diagnosis.
Cặp Phú bị điên quá mấy. Vụ đó cái thật sự.
We have more and more cases of travelers with exome. Today we can reach the results of exome. We can reach it in 10 days to 2 weeks. This is a fetal case of 2015. Patient referred because of microcephaly, no family history, no amniocentesis, the alpha fetoprotein was normal, early ultrasound screening normal with normal biometry, and this is the ultrasound at 23 weeks, and what you can see is a fetus with a very big head. You see that the relationship between the head and the face is in favor of the head, and the corpus callosum measured 37 millimeters at 23 weeks. That the normal corpus callosum should be a bit smaller, at least let's say smaller than 30 millimeters. Pregnancy continue, and here you see a corpus callosum of 49 millimeters that again is extremely large with microcephaly, and this is how the head circumference grows. At this point the family decided to go for termination, and after termination the diagnosis was of AKT3 variant. Here we have another case at 31 weeks and 5 days. The head circumference was 2.7. At 34 weeks and 6 days, it seems that this head circumference is smaller. Again, the fetus was not macrosomic, was large but not macrosomic. But these are the findings. You see here the abnormal sulcation and giration of the occipital horn. It's a very large corpus callosum, and the very big head in relation to the face. And this case turned out to be a de novo mutation in PIK3CA that we reached the diagnosis before termination of pregnancy. This is why we terminate. The head circumference at birth, the brain weight was plus 4.6 standard deviation, abnormal brain, also in the cerebellum they found polymicrogyria, and they have multiple vascular anomalies with facial dysmorphism. And here we have another case, okay, where we see very clearly the abnormal shape of the lateral ventricles. In my opinion, this is due to the fact that the corpus callosum is very big and it goes to the sides, so the lateral ventricles cannot go up because the fibers of the corpus callosum don't let the lateral ventricles to go out, so they become triangular and pointed. And here you can see the almost the complete lack of sulcation. But what's more interesting and what probably makes the diagnosis is the fact that you can see here at 26 weeks the presence of sulcation that is abnormal. This sulci and the shape of the cortex should be at 26 weeks is encephalic or without sulci, as you can see in this side. And also this fetus has a malformation that was diagnosed by exome. And also the post-mortem examination confirmed the presence of polymicrogyria, multifocal and bilateral, facial dysmorphism, and also hypertrophy of the first two that was bilateral. Again, another case, we have a large corpus callosum. Okay, the lateral ventricles were not dilated, and again here you see the abnormal sulcation. Wrong. Okay. This is the follow-up. At 34 weeks and 6 days, the head circumference reached 3 standard deviation. The corpus callosum was well larger than the 97 percentile. The patient decided to go for MRI, and the exome was expected after delivery. Okay, this is the MR showing the abnormal brain, and after termination, we found that P3 are mosaicism de novo. It was present only in the amniotic fluid fibroblasts in 8% of the cases, but in the brain tissue that we perform autopsy in 20% of the cases. And this is my last case. Okay, we will have this patient referred 23 weeks because of severe brain anomalies, and here you have the finding. The head circumference was 3.6 standard deviation. It was not trisomy. The brain parenchyma was clearly abnormal, starting from the ventricular wall to the wall parenchyma with abnormal, very abnormal sulcation, with a very abnormal cerebellum. And you have here the images at 23 weeks. Okay, it's very clear that the whole brain is abnormal. Okay, there were also other findings. Was a lot of fingers. Epidactyly was a very big thumb in the leg, and you can see here also in the 3D. And the pathology showed all the findings that we saw in the ultrasound examination.
Chị không ghi cái gì hết, chị không có ghi cái gì hết, chị không tự động sửa cái gì ở trên phần hành chính. Nó tự hiện ra sai là do cái gì của IT đó, chị không có biết. Vì chị không hề đụng tới cái địa chỉ và chị không sửa lại được cái đó, em hiểu không? Bây giờ chị không sửa được, chị không đụng vô được cái phần đó.
But we were surprised by the results of the exome sequence. It turned out that this fetus has a pathogenic variant in a gene that is called OFD1. That this pathogenic variant have been non-described previously in the environment. And this variant may produce different syndromes. Joubert syndrome number 10, orofacial syndrome, Simpson-Gorabe-Hamel syndrome, primary serial dyskinesis, and the phenotype was more compatible with Joubert syndrome. When we went to the literature, it turns out that these similar cases have been published, meaning that the normal phenotype of the OFD1 gene may produce serial dyskinesis with a Joubert-like presentation, but also with a presentation that, in my opinion, was also very similar to the Simpson-Gorabe-Hamel syndrome because of the presence of the fingers. So in conclusion, you have micro or macrocephaly with associated malformations, consider termination, and you can do the exomic sequencing later on. If you have an apparently isolated microcephaly or macrocephaly, the decision will be based on the exomic sequencing. And a provocative statement to finish: exome sequencing for all. Today, the recent papers, also from China, also from Israel, show that if you perform exomics in a low-risk population without ultrasound findings, the chances that you will find some pathogenic or likely pathogenic variants is around 2%. They found a little bit more. I am not sure that the results are 2%, but the chances to find something are quite high. So the first key, if family decide to go for genetic evaluation in pregnancy, should be straight exome sequencing. Don't do karyotype, don't do CNA, go straight for exome sequencing. Thank you very much.
Thank you, Gustavo. The nice lecture and very, very rare cases included. And there are several questions already that we had. However, we will have the Q&A session after Karina's lecture. So please wait for a little bit. And so the participants, if you have questions and comments, please put them in the question box. Okay, so the Karina, so next speaker. As for Karina, everybody already knows she's the top expert of the fetal brain from Tel Aviv, Israel. And Karina, with Gustavo together, published a lot of articles and book chapter. And she's the I think she's a perfectionist and also very thoughtful. And I always learn a lot from her all the time, and because of her thoughtful presentation and the very nice slides. And I promise you will also learn from her a lot today. So please, Nina, start your lecture.
Thank you, Ritsuko. Thank you, everybody, for being here, and thank you for your words. It's a double way, so let's speak a little bit about lissencephaly and dysphagia, and I really hope that you don't get very depressed from the lecture, because it's hard regarding fetal life. And we are going to bring some new aspects regarding the assessment of these entities in fetal life. So please just let me know that you see my slides. Okay. Do you, Ritsuko?
Yes.
Yes, Karina, yes.
Yes. Perfect. Okay. So, for the ones that do not know, I am Brazilian in origin, and I really do like football. So we are going to start, and Rick and Gustavo really have made my life a little easier regarding the background of the cortical development. So I will go straight forward to our point. And our main players regarding neuronal migration need to be understood for us to understand the complexity of the possible diagnosis, the overlap of the fetal phenotype of the different entities, and why do we find specific abnormalities in the brain in this and that disease. So the neuronal migration process is very complex, and it relates on different structures that need to be normally configured in the brain. So we have the radial glial cells, which will be the pathway of the radial migration, the microtubules, the microfilaments, actin, double protein, and many other proteins that are very important, transcriptor factors for the axonal guidance, the normal development of the extracellular matrix and proteins that are responsible for this development, the normal development of the meninges. So the meninges would be the pia mater, mainly will be the end point of the migration, and it's very important that it's completely normally developed and no gaps in the meninges. And there are many other factors that are important, but these are the main ones. And whenever we have abnormalities in the microtubule, so you have a tubulinopathy, you have a DNAinopathy in the microfilaments, and double protein. So we have different names that are secondary to the underlying mechanism of this. So I know that especially for us gynecologists, these names are very frightening, but we need to understand that, otherwise we won't make it into the process of the differential diagnosis. So first thing first, regarding the fetus, how can we even suspect that there may be an abnormality of migration, especially lissencephaly and dysphagia? So normally the main referral causes are ventriculomegaly, abnormal anterior complex. So although it's not part of the basic scan, but I really invite you guys to check on the anterior complex, presence of brain asymmetry. And if we go and check directly for the sulcation, so of course, signs of delayed or aberrant sulcation. And I will abort the topic of the head circumference later. Of course, if head circumference is small, it really helps us to suspect, but in most cases, unfortunately, during fetal life, the head circumference won't be small enough for us to raise suspicion on an abnormality. So it's not a very good screening point. We need to understand the normal development of the brain. So there are different maps we not only need to understand the main sulci when they appear and where, and unfortunately I have no time to discuss the normal development, and most maps, they are quite alike regarding the week that they offer the appearance, so we can choose whatever you like. And then we need to understand at least our three main fissures in order to start from the second trimester scan. So the development of the Sylvian fissure, and here is this piece of art from Ritsuko showing the development in coronal views, but it's not enough for us to check on the coronal view because the Sylvian fissure would be, it's three-dimensional, and in some cases the clue